Hello and welcome to this presentation on WFS PLUS. WFS PLUS is a product that has been specially formulated for physicians for the treatment and management of polycystic ovary syndrome or PCOS. PCOS is a syndrome often characterized by numerous small fluid-filled sacs or cysts in the ovaries and abnormal production of androgens, and is the most common cause of female infertility. Because PCOS is a syndrome characterized by many positive symptoms occurring together, there is need for a product that deals with these symptoms at the same time. In addition, many women with PCOS have insulin resistance, which means their body cannot use insulin well and have deficiency of vitamin E and D. WFS Plus is a special formula specially made for this syndrome and targets many symptoms in PCOS. The following are the benefits of WFS Plus. It supports women with PCOS. It improves insulin sensitivity and reduces insulin resistance, thereby improving glucose metabolism and usage. It helps regulate the menstrual cycle, which is important because women with PCOS often have irregular cycles, and it reduces hyperandrogenism. WFS Plus has the following ingredients: dikairoinositol, N-acetylcysteine, docosahexaenoic acid or DHA, calcium or lipoic acid, vitamin C, vitamin D, biotin, choline, magnesium, and manganese. The combination and concentrations of these ingredients is evidence-based and unique to WFS Plus. This is a brief introduction to polycystic ovarian syndrome. Polycystic ovarian syndrome is the most common metabolic disorder in women of reproductive age. Polycystic ovarian syndrome is an important cause of ovulatory and menstrual irregularity, subfertility and infertility, clinically evident hyperandrogenism, and metabolic dysfunction in women. Polycystic ovarian syndrome as a disease also has a lot of complications and is a major predisposing factor for diabetes, metabolic syndrome, and cardiovascular diseases. The following are the common symptoms of polycystic ovarian syndrome: excess body hair or hirsutism, including on the chest, stomach, and the back; weight gain and obesity, especially around the abdomen; infertility and oligomenorrhea, meaning missed periods or irregular periods or very light periods. Other symptoms include ovaries that are large or have many cysts, acne or oily skin, male pattern baldness or thinning hair, small pieces of excess skin or skin tag on the neck or armpits, and dark or thick skin patches on the back of the neck, in the armpits, and under the breasts. These are the typical frequencies of signs in polycystic ovarian syndrome: hirsutism 85 to 90%, infertility 73 to 75%, abdominal obesity 30 to 70%, metabolic syndrome 40%, type 2 diabetes 10%, and arterial hypertension 20%. According to studies, obesity is very common in patients with polycystic ovarian syndrome and occurs in between 30 to 75% of the patients, making it the most common obesity-related endocrine syndrome in females. Hyperandrogenism or elevated testosterone is also common in polycystic ovarian syndrome and is manifested clinically by hirsutism, acne, male pattern balding, and cutaneous manifestations. As illustrated in this diagram, insulin resistance plays a central role in polycystic ovarian syndrome at various levels. Overall, insulin resistance and the compensatory hyperinsulinemia affect some 65 to 70% of women with polycystic ovarian syndrome. Part of the insulin resistance appears to be independent of obesity and related specifically to the syndrome, with abnormalities of cellular mechanism of insulin action and insulin receptor function having been documented. The hyperinsulinemia appears to be an important factor in maintaining hyperandrogenemia, acting directly to induce excess androgen production by the Veka cells. Insulin resistance also leads to oxidative stress and to high levels of reactive oxygen species compared to antioxidants, leading to abnormal maturation, abnormal luteal phase, and infertility. Consequently, it is imperative to resolve insulin resistance in polycystic ovarian syndrome, and that's why N-acetylcysteine and dikairoinositol have been included in WFS Plus. As illustrated in this diagram, insulin resistance is a pathophysiological contributor in 50 to 80% of the polycystic ovarian syndrome in women. Consequently, the most desirable goal of treating polycystic ovarian syndrome subjects is to increase insulin sensitivity and to improve lipid profile. This diagram illustrates the multifactorial nature of polycystic ovarian syndrome involving multiple organs and systems. In summary, insulin resistance and hyperinsulinemia, together with the resultant positive feedback from the pituitary gland producing excessive amounts of LH, plays an important role in the pathophysiology of functional ovarian hyperandrogenism, which leads to ovulation and other symptoms such as obesity. High androgen levels prevent ovulation, and this causes irregular menses. The following are the three main theories explaining failure of ovulation in polycystic ovarian syndrome. 1. Excess production of androgens from follicles in the ovaries, resulting to failure of ovulation. 2. Excess production of LH by the pituitary, which stimulates the ovarian follicles to release excess male hormones, resulting in failure of ovulation. And 3. Increased insulin in circulation due to insulin resistance, which stimulates the ovarian cells to produce excessive amounts of male hormones, which causes failure of ovulation. We will now focus on studies on polycystic ovarian syndrome. This study demonstrated the central role that insulin resistance plays in polycystic ovarian syndrome and demonstrated the associated low-grade inflammation that accompanies the syndrome, especially in patients with insulin resistance. Studies have demonstrated the centrality of insulin resistance and its compensatory hyperinsulinemia in the pathophysiology of polycystic ovarian syndrome. For example, this study demonstrated the presence of insulin resistance in both obese and lean women with polycystic ovarian syndrome and showed that administration of insulin sensitizers such as dikairoinositol and N-acetylcysteine ameliorates hyperandrogenemia and increases ovulation frequency. According to studies, insulin resistance is a pathophysiological contributor in 50 to 80% of the polycystic ovarian syndrome in women, and in addition predisposes these women to dyslipidemia, hypertension, impaired glucose tolerance, type 2 diabetes, and cardiovascular disease. This slide summarizes normal glucose metabolism and highlights the central role of phosphatidylinositol-3 kinase, also known as PI3 kinase. First, insulin binds to its receptor and forms a complex called insulin receptor substrate, IRS. IRS then stimulates a messenger called PI3 kinase. After this, activated PI3 kinase activates GLUT4 through glucose channel for utilizing energy. Finally, the IRS complex breaks down, releasing the receptor to go back to its original site. PI3 kinase is a key messenger, and its production and activation is crucial for normal cell glucose metabolism. Inositol produces and activates PI3 kinase. PCOS patients have insulin resistance due to deficiency of dikairoinositol, a discovery made in the 90s through a study. Consequently, it is very important to supplement PCOS patients with dikairoinositol, whose deficiency leads to insulin resistance and other complications associated with the syndrome. This study highlights the central role of dikairoinositol in normal human metabolism and its role in PCOS state and type 2 diabetes mellitus. PCOS and type 2 diabetes mellitus are caused by functional deficiency of dikairoinositol, either through dysfunction of the enzyme that produces it or an overly efficient excretion method of dikairoinositol from the body. According to this study, dikairoinositol deficiency in PCOS patients could be explained by three mechanisms. 1. PCOS patients had 5 times dikairoinositol urinary clearance compared to normal patients. 2. PCOS patients had impaired dikairoinositol IPG release in response to insulin. And 3. PCOS patients had defect in tissue availability and utilization of dikairoinositol. This diagram shows that PCOS patients have low plasma concentration and high urinary clearance of inositol. This study demonstrated that urinary clearance of inositol in PCOS patients was 5 times higher than the clearance of inositol in normal individuals. This diagram summarizes the consequences of deficiency of dikairoinositol in PCOS patients. Deficiency of dikairoinositol decreases PI3 kinase activity, thus decreasing glucose uptake and utilization in response to insulin, resulting to insulin resistance. This study found that oral administration of dikairoinositol in PCOS patients led to increased insulin action. Specifically, administration of 1,200 milligrams of dikairoinositol for 6 to 8 weeks led to a reduction in serum free testosterone by 55%, increased serum sex hormone binding globulin concentration, reduced diastolic and systolic blood pressure, reduced plasma triglyceride concentrations, and significant improvement in ovulation, with 86% of intervention women ovulating compared to 27% of controls. The conclusion of the study was that dikairoinositol increases the action of insulin in patients with PCOS, thereby improving ovulatory function, and decreases serum androgen concentrations, blood pressure, and plasma triglyceride concentration. This study evaluated the effects of dikairoinositol treatment on ovarian function and metabolic factors in women with PCOS. The results showed statistically significant reduction in systolic blood pressure, LH-FSH ratio, total testosterone, free testosterone, androstenedione, prolactin, and HOMA index. It also showed significant increase in sex hormone binding globulin and significant post-treatment menstrual cycle regularization. The study concluded that dikairoinositol was effective in improving ovarian function and metabolism of patients affected by PCOS. This systematic review investigated the significance of dikairoinositol on PCOS. In the study, it was confirmed that PCOS women had less dikairoinositol IPG release, which corresponds to insulin resistance and hyperinsulinemia seen in these patients. It was also found that dikairoinositol had beneficial effects on ovulation, anthropometric and metabolic markers in these patients by its action on enhancing insulin sensitivity. Finally, the study demonstrated that the effects of metformin in improving insulin action in these patients was mediated through the release of dikairoinositol IPG mediators. Dikairoinositol administration ameliorates insulin resistance, hyperandrogenemia, and improves ovulation in PCOS, while administration of metformin may act to release the dikairoinositol IPG mediator that tells the cells to use or store glucose. It does not increase the amounts of available dikairoinositol, which is deficient in PCOS patients, and this explains why metformin is effective in some, but not all PCOS patients. On the contrary, administration of dikairoinositol increases the release of dikairoinositol IPG mediator through increasing availability of dikairoinositol. In addition, dikairoinositol increases the levels of the sex hormone binding globulin, thereby further decreasing testosterone levels, and it also breaks down fats and decreases blood cholesterol. This retrospective study investigated the modulatory role of dikairoinositol on the LH and insulin secretion in obese patients with PCOS. The study concluded that administration of dikairoinositol was effective in improving ovarian function and metabolism in patients affected by PCOS. This diagram summarizes the benefits of dikairoinositol. The benefits include improved insulin sensitivity, decreased insulin resistance, improved glucose utilization, reduced free circulating testosterone, restored menstrual and normal ovulation, and improved pregnancy rates. Another key ingredient in WFS Plus is N-acetylcysteine. N-acetylcysteine is a potent antioxidant and a precursor to intracellular glutathione, which is yet another powerful antioxidant. In addition, N-acetylcysteine improves insulin sensitivity in PCOS patients with hyperinsulinemia and in patients with type 2 diabetes. Another important attribute of N-acetylcysteine is that it lowers the levels of homocysteine and TNF-alpha that are usually present in PCOS. Elevated levels of homocysteine and TNF-alpha worsens PCOS. Addition of N-acetylcysteine to clomiphene citrate in patients resistant to ovulation induction with clomiphene citrate increases response rates. For example, in this study, the addition of N-acetylcysteine to clomiphene citrate increased the rates of ovulation to 49% compared to 1.3% and pregnancy rates to 21% compared to 0%. This study, published in the European Journal of Obstetrics, Gynecology and Reproductive Biology, compared the effects of N-acetylcysteine and metformin on insulin levels in PCOS patients. Both treatments were equally effective and significantly decreased body mass index, hirsutism, fasting insulin, free testosterone, and menstrual irregularity. However, N-acetylcysteine led to a significant decrease in both total cholesterol and low-density lipoprotein levels, whereas metformin only led to a decrease in total cholesterol levels. This randomized double-blind clinical trial, published in the official journal of the International Society for Gynecological Endocrinology, compared N-acetylcysteine and metformin in PCOS, and it measured effects on fasting blood glucose and insulin, lipid profile, and homeostasis model assessment index, HOMA. In summary, the study results showed that N-acetylcysteine improved lipid profile, fasting blood sugar, and fasting blood insulin better than metformin. Other studies have affirmed the role of N-acetylcysteine in infertility. In the first study, N-acetylcysteine was shown to increase peripheral insulin sensitivity and to significantly decrease total circulating testosterone levels. It was also demonstrated to significantly decrease total cholesterol, plasma triglycerides, and low-density lipoproteins, with no noticeable side effects. However, these results were confirmed only in hyperinsulinemic patients. The second study demonstrated that N-acetylcysteine plus folic acid compared with folic acid alone significantly increased the rate of continuation of living pregnancy greater than 15 weeks by 73% compared to 20%. Finally, the last study showed that combination of N-acetylcysteine with clomiphene citrate significantly improved pregnancy rates in intrauterine insemination cycles of patients diagnosed with unexplained infertility. This slide summarizes the clinical effects of dikairoinositol and N-acetylcysteine. Dikairoinositol improves insulin sensitivity, decreases serum testosterone, decreases blood pressure, reduces plasma triglycerides, and improves ovulatory function, while N-acetylcysteine reduces homocysteine levels, increases glutathione, reduces plasma triglycerides, reduces insulin resistance, and normalizes plasma insulin levels. N-acetylcysteine also reduces oxidative stress and lowers TNF-alpha levels. This study investigated the role of reactive oxygen species-induced oxidative stress in the development of insulin resistance and hyperandrogenism in polycystic ovarian syndrome. It demonstrated that oxidative stress in PCOS patients occurs as a result of hyperglycemia irrespective of obesity, and that the resultant pro-inflammatory state induces insulin resistance and hyperandrogenism. The study concluded that antioxidants play an important role in the management of PCOS. R-lipoic acid is a powerful antioxidant, and it has the unique ability to cross the blood-brain barrier. R-lipoic acid is a special antioxidant because it helps the body to reuse available antioxidants such as vitamin E, vitamin C, glutathione, and coenzyme Q10, and in addition, it has the ability to chelate heavy metals such as lead. Finally, studies have shown that R-lipoic acid can greatly reduce inflammation through modifying gene expression and decreasing TNF-alpha levels, which worsens PCOS. Docosahexaenoic acid, or DHA, is another powerful antioxidant in WFS+. DHA is an omega-3 fatty acid that improves levels of lipids in the blood and is a component of the human brain, skin, ova, and sperm. DHA also decreases inflammation and TNF-alpha levels, which worsen PCOS. Finally, studies have shown that women who receive DHA experience a longer gestational time, and that it helps pregnant women avoid two serious conditions that can occur during pregnancy, that is preeclampsia and gestational diabetes. In addition, studies have linked low levels of DHA in the brain to decreased risk of developing postpartum depression. Vitamin D deficiency is common in PCOS patients. Studies have linked low levels of vitamin D to insulin resistance, which is central to the pathophysiology of PCOS. In addition, vitamin D also reduces the levels of TNF-alpha and other inflammatory mediators. Calcium also improves insulin sensitivity and plays a role in weight loss. For example, this study demonstrated that supplementation with calcium and vitamin D in vitamin D deficient women with PCOS had beneficial effects on serum insulin levels, serum triglycerides, and cholesterol levels. Vitamin C is also a potent antioxidant and reduces oxidative stress. Further, proper ratio of vitamin C is required to stabilize N-acetylcysteine, and in addition, vitamin C has a protective effect within the follicle. Other ingredients in WFS+ are manganese, biotin, choline, and magnesium. In summary, manganese reduces hyperglycemia when taken with dikairoinositol and reduces reactive oxygen species in mitochondria. In addition, manganese is involved in carbohydrate, cholesterol, and amino acid metabolism. In fact, deficiency of manganese has been associated with retarded fetal growth in the uterus. Biotin may improve glucose tolerance, increase insulin sensitivity, and lower triglycerides. Choline is a precursor to acetylcholine, helps in regulating homocysteine levels, and reduces the risk of neural tube defects. Finally, magnesium has a strong correlation to insulin resistance, improves diabetic hyperinsulinemia, and decreases systemic inflammation. The daily dose of WFS Plus is 6 capsules daily in divided doses, preferably after meals. WFS Plus has been specially formulated for physicians and delivers therapeutic doses of the ingredients based on scientific evidence and studies. Duration of use is 3 months, but could be extended based on clinical outcomes and physician's preference. WFS Plus provides a new approach to treat PCOS without the use of hormones or clomiphene citrate that may have major side effects. It provides an alternative, natural approach for managing PCOS and its various symptoms such as hyperinsulinemia, hyperandrogenism, irregular cycles and infertility, and abnormal obesity, among other symptoms. Treating insulin resistance and hyperinsulinemia using the combination of inositol and N-acetylcysteine corrects hyperandrogenism, and by lowering testosterone levels, regularizes the menstrual cycle and improves symptoms associated with elevated testosterone such as hair loss, acne, oily skin, and hirsutism.